Hello and welcome. My name is Donna Cryer. I'm the founder and CEO of the Global Liver Institute, patient-led advocacy organization that operates in the United States and in Europe, and soon to be have offices in the UK. So I am very excited to be doing a very special episode on today in the United States is National Hepatitis Testing Day. And I could think of no better expert and advocate to help me discuss this topic than Dr. Su Wang. Su is the president of the World Hepatitis Alliance, as well as being the medical director for the Center for Asian Health at Saint Barnabas Medical Center. She also leads their viral hepatitis program. So she is the full package, physician, patient, expert in hepatitis. And also it's very exciting to do an episode, brought to you by women of color during Asian American Pacific Islander Health Month. As we've discussed before, my feeling about these certain months, I'm a person of color all months. And so
true.
We need to make sure that these issues are not just congregated or siloed in one day, but really that we use these days and months as platforms for greater exposure, greater connection, and to inform ourselves of the experience of people who might not be in our normal networks. And so with that, I just want to say welcome, Dr. Wang.
Thanks for having me. I think that was a great lead up, and I agree. This is a good chance for inclusion, but it should be something we think about daily in terms of diversity. And I think equity, right, comes up in so much of what we do in healthcare, and specifically with hepatitis. There are many, many gaps. And so what we have been, I think it is an opportunity, though, kind of like what you're saying, when we do have certain days, and today is National Hepatitis Testing Day, to address those issues, because health equity will play into health outcomes. And if we're trying to get to hepatitis elimination, we must address those equity issues. And if we don't, we will have a difficult time and may not be able to get to hepatitis elimination.
Absolutely. So tell us, just as we start, what is hepatitis? What are the different types of hepatitis, and how do you test for them?
So yeah, hepatitis, the word itself just means inflammation. Any kind of itis is an inflammation, and it's an inflammation of the liver. And so there can be viral hepatitis conditions. There can also be non-infectious hepatitis, which you can see like autoimmune hepatitis, right? But viral hepatitis is caused by a number of different viruses, and they actually are very different. So besides the name hepatitis, they don't have that many shared, they don't all have similarities besides their name. So there's hepatitis A, hepatitis B, hepatitis C, hepatitis D, hepatitis E, and people can get lost. It's like alphabet soup of hepatitis, right? And even as a medical student, some of these are fairly new. And so hepatitis B and C were all discovered within the past 40 years. So those people who went to med school before that may not have studied it. Or for a while, Hep C, was known as non-A, non-B hepatitis. And we've heard that story told so well by Harvey Alter and the other Nobel Prize winners in terms of how it went from non-A, non-B transfusion hepatitis into hepatitis C. So I encourage people to listen to those stories, because it's so interesting, right? Just hearing discovery of viruses and getting to us to where we are, where we have cures for Hep C and we have treatments for Hep B and vaccines for Hep B. I mean, it's amazing what medicine has done in terms of research, that in the span of just a couple of decades, we've gone from discovery of these new viruses to now being able to combat them, prevent them, cure them. And really, we need to get to the point where we can apply all these tools to everybody. That way we can actually eliminate them, because that would be the ultimate story, right? Discovery, treatment, cure, prevention, and finally eradication from our planet. But the major ones we're going to focus on that cause the greatest burden of disease are hepatitis B and C. And that's largely because they do become chronic and can lead to cirrhosis. and they are the leading causes of liver cancer. And liver cancer, I think, is, if we were talking about like ignored conditions and health equity issues, it's just one of those conditions that gets overlooked, right? I think I'm a primary care doctor, and there's so much focus in all of my medical, when we talk about clinical quality measures, it's all about breast cancer screening, colon cancer screening, how are my diabetics doing? How are my hypertensives doing? Like we look at all these measures for insurance payment plans, but there's not, liver cancer does not rise there at all at this point. And yet it is the third most deadly cancer, and it's on the rise both nationally and globally. So we as advocates need to, raise awareness, just like we are with, minority groups. I think it's a minority, this is like a disease. It's a minority disease we need to raise awareness for.
And we'll be doing more of that in October. Our Liver Cancers Council at GLI.
Oh, that's great.
Is arranged and ready. They're like, as soon as you finish with that, International NASH Day thing.
Move on to the next thing. Yeah.
A NASH and liver cancer panel on the 10th as well. I think because, and as a liver patient myself, I know that any liver disease, if left to its own devices, can unfortunately develop into cancer. Or the need for transplant. I've had the transplant. I'm trying to dodge the cancer. And so you're right, raising awareness of that in the context, and it's something that can unite all of the liver and all of the liver organizations in wanting to prevent cancer. And so much of the conversation in research is about preventing cancer or finding a cure for cancer, and yet we have some. If you prevent a lot of the liver diseases, if you give a vaccine for hepatitis B, if you give the cures for hepatitis C, you really are preventing cancer. And so it's a really fantastic story, both of innovation, but public health as well.
Right. I think that's a great way to see it. I think patients understand that too. I think cancer is just very tangible. And so if you consider it like where this is many paths that can lead to liver cancer, where can we stop people, intervene along the way? And so for, Hep B and Hep C are really some of the top drivers, along with fatty liver. Hep A is a more of a fecal oral transmitted disease that happens through food, unclean water. And that one does not become chronic. Hepatitis E also similarly can be transmitted through dirty water. And so Hep A and Hep E don't become chronic, but B and C do. And so those are the ones we're most focused on to prevent liver cancer.
I've been surprised to see so many reports lately about hepatitis A outbreaks. And they are mostly in agricultural communities where people don't have access to proper restrooms, and there's water contamination and things. And so
yeah, and actually in the US, we were like right in the midst of a huge national outbreak a couple years ago, I think, in homeless populations. And actually even here, like in New Jersey, we were having issues in restaurants, delis, like I think one of our local grocery stores, and even a country club. So it was hitting all spheres of life. And we were just telling people, you know what? We have a vaccine. It's really easy. Like, just go get vaccinated, and you never have to worry about it. So it is great, I think, as all of us who work in different fields of liver disease, to come together and put it as a package to people, right? It's difficult for people, even and physicians, to keep track of like, oh my gosh, what do I need to know about this infection, but just say, hey, this is all part of liver care. And if you do it that way, then it's like, oh, okay, liver cancer screening, that's, Hep B, Hep C, fatty liver screening. I'm going to do it all. I'm going to protect that. I already do alcohol counseling, right? So it's all along the same vein. And so that's what I tell patients. I'm going to do, you're a new patient. I do routine screening for all these conditions. I don't try to risk stratify you. This is not some sort of, thing where I think anything about you. This is just, good care. And we do Hep A, Hep B, Hep C. We do HIV. I do all the metabolic screening, and people are fine with that. So, yes, I agree with what
I love that approach. I love doing a liver health assessment, a liver health screening in a primary care setting. So it is set both in the physician mind and in the patient mind that your liver health is something that you should be aware of and take care of in the same way your heart health or your brain health.
Exactly. Yeah.
Fantastic. I was screened for hepatitis B before my transplant, certainly, and before I started on a biologic for my inflammatory bowel disease. And yet there is often resistance in certain specialties or clinical workflows to screening for hepatitis B or screening for hepatitis. And how can we get over those, particularly on days like today? Because I want to make sure that every patient listening to this episode understands where to go to get screening, how to get screened, what
Right.
screening, what testing means for the different forms of viral hepatitis.
Yeah, I think it's really interesting when you watch kind of the history of testing for various viral conditions evolve, right? So for HIV and for Hep C and for Hep B, it's been a lot of like risk assessments. Oh, we have the data to show it's worth it, cost effective, like for Hep B, for example, to test those whose parents are from in endemic countries, or if you were born in a country where Hep B is endemic. And so they give us this map of all the countries, and like how often is a doctor going to go through that map and say, where are you from? Let me look this up. And then Hep B has this long condition. If you're a dialysis patient, if you're a man who has sex with men, if you are multiple partners, if you have abnormal LFTs, if you are on immunosuppressives, it's this list like this long.
Right. And
right.
You could have just tested me, or
and honestly, as a doctor, I have such limited time with patients. If you're going to give me that, I'm going to be like, no, this is not my ball game. That's too complicated.
Right.
And it used to be that way for Hep C, and literally just last year, CDC updated the guidelines and said, we know there's enough evidence to say that Hep C occurs in people outside of the baby boomer range. The epidemic's changing. We're seeing younger people with it. Everybody, and at least a one-time test. And if you have risk factors, then you do it more often. And there was a recent publication that just came out like last week, Clinical Infectious Disease, by a group and CDC and the Asian Liver Center, doing assessment of what would that be for a Hep B if we did a one-time test. And they have shown it is economically worth it. We would actually save millions of dollars each year. We would save lives. We would save 10 deaths per 100,000 people who would be screened. And so beyond the fact that this is a good idea because, we get people diagnosed and treated, and we're preventing liver cancer, cirrhosis, and people transmitting the virus, right? People can get treated once they know. Economically, it makes sense, right? Because there's less people who need liver transplants, who need additional care because they have cirrhosis. And so I think we're moving towards that with Hep B too. Right. I think CDC is, gathering the data where we might be at a point, soon where we're saying everybody should just know your status. And honestly, with the chance to get a vaccine, why would you wait? Why would you not try to get vaccinated? So those of us who were born after 1991, before 1991, before the pediatric vaccines were implemented in childhood, we didn't get the vaccine. Obviously those of us in healthcare, have had the opportunity to do so. But if not, there's a huge gap. There's a lot of adults out there who have not been vaccinated. So this is a chance to get them screened and also get them vaccinated.
I agree. And I think that more universal screening is the most efficient. And I will put that paper in the show notes.
Oh, great.
I've also been part of a group with ASCO looking at screening for hepatitis B prior to
chemo, right? Or immunosuppressives. Yeah.
So making sure that because if people undergo chemotherapy, if they have sort of latent hepatitis B, it can activate.
It can flare, yeah.
Hadn't been before. And how horrible for a person to have then active hepatitis B and cancer.
Oh, yeah. We've been hearing all sorts of stories. They're tragic. It really is tragic. These people who have cancer are found out too late that they have Hep B. It reactivates and they end up dying of fulminant liver failure. They are not eligible for transplant because they have cancer, and it could have been entirely preventable. So yeah, Donna, I'm with you on that ASCO task force too. And you remember the conversation was, it actually really makes sense to do universal screening because then rather than find out once you already have cancer, how much better would it have been if you were able to have this addressed beforehand? And my, role there as the primary care physician is, hey, remember us, we take care of the patients also,
Right.
and we can help you with this. If the patient knows that they have B, they can walk into your office saying that, and you don't have to worry about potentially missing the diagnosis. And we can help you with that. We're a team, right? We can help you make sure that they're on treatment if they need it for reactivation or for themselves, right? Potentially they could have used the treatment, because of their liver condition. So.
And, Sue, that's just one of many, many examples of why you are such a powerful ally. You are both physician and patient as well. Can you tell us about the patient story, the patient side of your story?
Sure. So my story is, my parents come from Taiwan. My mother's side of the family, so her father was a dentist and her mother was a midwife. And so they were healthcare, in the healthcare field. And at that time, there was no universal precautions. Nobody was using gloves. And so there is a really good chance they got hepatitis B just from their work. And they only found out later that they were infected. And I didn't find out, a lot of this has only this is all in retrospect now, right? Nobody knew while they were working and stuff. But I found out that I had Hep B when I went to college and donated blood, right? And I can't tell you how many people I've heard that same thing. They got diagnosed not by their doctors, but by donating blood, right? So you can tell right away there's some gaps here. And it was overwhelming. I had no idea how I gotten it. And my sister had, at that point, I told her, she goes, oh, I think mom had it at some point. We've since found out that my mom never had it. Her core antibody is positive. So I think I probably got it from my grandparents early on in childhood through some exposure. And at that point, and I think this is the case with probably a lot of people, when we talk about, oh, don't patients want to be diagnosed? Don't they want to be found? Honestly, people just want to live their lives, right? So if you get a diagnosis, you might just kind of put it on the back burner and say, I hope this doesn't impact my life. And I went through med school. I had gotten a doctor and who treated me, my viral load. I mean, not treated me, but tested me and found out my viral load was low. So I was like, okay, at that point we weren't really doing a lot of treatments. And I got by. So somehow, now I've seen a number of cases where healthcare workers end up getting discriminated because of their.
I was going to ask about
that. Because they write down they have Hep B, and it creates this uproar like, oh my gosh, are you going to infect everybody? There is no reason somebody with Hep B cannot pursue a healthcare profession. And so CDC has come out strongly on that. The Department of Justice was brought in for a number of discriminatory cases where students lost their acceptances, residents lost their positions, doctors were not given their licenses to practice in certain states. And it was just horrible experience for a lot of people because, they brought in lawyers and it was, when we talk about HIPAA protecting patients, there was no HIPAA for these students. Their deans knew about it. There were these public panels and, it was just a horrible feeling. And a lot of them never wanted to report it, right? They just wanted to keep their business, some of them are young, they're Asian and their parents don't want to make a big fuss and they don't want to jeopardize any future jobs or school acceptances. And so it's because of advocates. So like the Hep B Foundation that really took on their cases, did the work of working with the Department of Justice. And now we have HHS has made, really strong policy that this is like HIV, it's a protected condition and it is considered discrimination to based on that, diagnosis alone for people not to be kicked out of school or to lose jobs. So we've made progress, it's really showed that advocates really make a difference. And so anyway, I was lucky that did not happen to me. I think, somebody just looked at the paperwork and really maybe didn't really look at it. I was lucky. I had some close friends that I had told, and one of them was an infectious disease doctor. And I was at Georgetown doing my med peds residency. And she said, you should probably get ongoing care with the hepatologist. You should probably see somebody. I was like, but I feel fine. I did the typical thing. I have no symptoms. And thankfully for her, I did end up seeing and getting in touch with a hepatologist and getting care. And My husband got vaccinated after we met. So I feel like I've been blessed with like good support.
Mhm.
Obviously, being in the healthcare field, I've had like the benefit of, having access to a lot of knowledge and understanding where we are in this field. And
Mhm.
after I finished residency, I ended up working in a Chinese FQHC, Community Health Center in New York
Mhm.
City. And I mean, at that point, I'd not gone public. Nobody knew that
Mhm.
besides really, really close friends. But I was handed over basically the Hep B portfolio at our health center and said, hey, you have public health background. Can you help us with this?
Mhm.
So I started doing a lot of work, designing programs, clinical programs for patients, doing community
Mhm.
outreach, and work with the health department and CDC, just becoming more vocal about representing our patients who obviously a lot of them don't have a voice. People are afraid to talk about it.
Mhm.
And I remember just, there was all this frustration of, we work with the New York City task force, and we say, wow, it's so hard to find Hep B patients. Nobody wants to speak out. And I feel like such a hypocrite, like, oh, like I wanted those people. But at some point it was that, somewhat anger and like
Mhm.
also like realizing that this is just, I have been, I am not somebody who feels at this point so vulnerable about my status.
Mhm.
So during an interview I gave, I did talk about it. And it's taken some time, to just be more comfortable
Mhm.
about being a patient, getting past the concern that, wondering what people think of me, my peers, my patients,
Right.
friends. But I think along the journey, what's been really important is just meeting other patients. We give each other the strength, we hear each other's stories, we embolden each other. And over time, like I've met some amazing people from around the world who have shared their stories, and they've gone through, really difficult times, and people have faced many, many challenges with stigma and discrimination around the world, to the point where I feel like this is really an important role for me and for many of us to really tell their stories, right? They're afraid, they've been abandoned by family
Right.
members, they've lost jobs, they've, had been divorced or contemplated suicide.
Mhm.
We need to tell those stories so people actually have an empathy for
Right.
hepatitis and realize this is important. And I think that's what was so effective about the HIV movement, right? You
Mhm.
had patients who were not shy, who were out there fighting, and it made people care about, this condition. Whereas hepatitis has largely been invisible because it affects minorities and marginalized
Mhm.
populations. And so now, and I think this actually does go hand in hand kind of with what's happening with the Asian Pacific Islander community and becoming more vocal to fight
Mhm.
racism. I think we're also realizing, hey, we have to stand up for our community and the conditions that that are more, affect our community more. So I do hope that as we kind of have this racial reckoning, right, we have a reckoning of
Mhm.
advocacy also in terms of just standing up for the things that are affecting our community.
I think that's a wonderful message, and I certainly stand with that. I had worked with several Asian medical associations back when I was, working at a public relations firm on a hepatitis B franchise, and so um, it was a wonderful opportunity to go from New York and to Seattle and really
Mm-hmm.
talk with people and learn with people. What were they thinking? What were the barriers? What were the stigmas? How do they communicate that to your families? How do you think about Western medicine and
Mm-hmm.
the traditional medicines that you were taught to use at home? And so it's so important that we think about healthcare in the context of people's lives and in the context of people's cultures. I was musing today on the words compliance and adherence,
Oh
and
yeah,
I
yeah.
certainly don't like compliance. Nobody
No,
that compliance
yeah.
thing.
It's a very paternalistic view of medicine, right?
Yes.
Yeah.
And so really working with people to because I have a pretty extensive healthcare regimen of things that are both prescribed, but also just how I exercise, how I eat, what I take at different times, and I think figuring out the why for people?
Yeah,
Why is
so
this,
important.
and do you trust the sources of information? Do you trust the prescribers and the nurses or your coaches, or whoever is helping you, reach your optimal health? And
Right. And everybody will have different values, right? And I think that's something that's becoming more discussed is like the preferences and the values of patients, right? That has a place at the table, just like, medical science and research does. And that's why, I think we're seeing more of this. What you and I are on the ASLD patient advisory group. It's so great to see us evolving where we are becoming partners with our providers, right? And they're seeing that, if in order to get to optimal compliance, right, you need to get patient engagement. You need to understand what it's like living the life with the condition. And I so there's more work, happening with PROs, patient reported outcomes, and I think it's really important because so much of the burden of the disease is not seen in blood work. It's not in symptoms. It's like the psychosocial measures, which we don't measure, but it's that burden of the disease. And so with hepatitis, a lot of it really is your labs can be completely fine, but it's still weighing on you so heavily. The fear of transmission, the just fear of what other people are thinking of you, fear of liver cancer. And so I think we need to figure out how do we mold that into our care for the patients. So I think we need to do more work in that area. And what you're saying in terms of background, obviously, like those of us who are Asian, like Eastern versus Western medicine is a really big thing, and I tell people all the time, you can't just shut it down and say, oh, we don't believe in Eastern medicine, poo-poo it.
Right.
The patient is not going to believe you, doctor, when they have like years of they come from this background that's so strong and their family believes in it. And and we need to be humble. We don't understand all these things. Like there's so much about alternative medicine that is proving to have, some real scientific merits to it. And of course, I'd rather somebody go on do acupuncture that end up needing back surgery, right? And so for pain, for a lot of things, we're still learning quite a bit of things. So I think that cultural humility that, coming from the providers is really important too. And I think just the experience of being a patient. So I'd say as a physician, I had breast cancer last year, really early stage, but I went through surgery and I got connected with the breast cancer community. And I have to say, like, it was what I learned from those forums, like listening to patients, how they lived, like post-surgery, post-mastectomy, like how they dealt with the pain, like that helped me in my quality of life. So much more significantly than like what I was able to glean from my physician conversation, for 5 minutes. Not to say there was anything wrong with that, but there's just a whole nother aspect of living with the disease that we never touch on as physicians. And so patients, I think, really we are the ones who can help each other, improve our quality of life. Right. So that needs to be part of the plan somehow, right? Part of the medical plan.
Right. I do try to take the time to go back to my physicians and let them know these other things that I'm doing, other things that have been helpful. Certainly as 26 years post liver transplant and with a new personal record on my Peloton yesterday. Okay, thank you. And so I want to make sure that they know these things so that they can share them with their other patients. That this is going on and that this is also providing the fertile soil for the medications and the other traditional interventions to take root and to have the best chance of succeeding. So I do try to.
And what do you find is their response, or what information do they find useful that's helpful? Because you're right. We never take these medicines, right? How would we know what it feels like? So
it's been a range of things. Sometimes it is, for example, both my mother and I find a particular type of iron helpful for anemia. And so, I just let him know, the brand and the type that I was taking. And, my proof point for his, scientific side was, look, we've been able to extend the timing of my IV iron By 6 weeks, we doubled the time that I didn't need to have an IV iron infusion when I changed to this type of iron.
Okay, so that's convincing. Yeah.
Like I have a couple of other patients that, they'll need for, or sometimes it's just like, you've asked me to do this, this, and this, and this. This is how I figured out how to do it.
Yeah.
And he's like, okay, I'll suggest to some of my other patients that's something that could work for them.
Yeah. Or even with the iron, like, even if it just makes you take it more, because like iron can have, side effects. People get constipated. So if it's less constipating, then yes, I need to know. So patients are more likely to take it, right? If
exactly.
They don't, yeah.
And so that was the issue for my mother. For me, it was absorbability. And so, and it's something commonly available on Amazon. And so, it was, something that we shared. Hopefully it's helping other patients.
Yeah, that's great.
So one of the things I wanted to ask you that, in listening to, you talk about, care delivery and has telehealth affected your or helped your ability to reach out to patients during COVID, or how has COVID affected your work and our efforts to eliminate viral hepatitis?
Yeah, we know COVID was, is still a disruptor. It obviously made it very difficult at times, especially when we were really kind of like in shutdown mode or lockdown mode, where people weren't getting services. So obviously telehealth was huge in terms of allowing people to still see their doctors and still maintain some level of connection and, continuing their medical care. So no, I think it's huge plus. Obviously not available everywhere either, and not all people are comfortable with it. But it's a really, really important tool that, I think is not going away anytime soon. But obviously there was overriding that, there was still fear of people going in. So even when things are reopening, and I try to assure people that healthcare facilities are obviously very conscientious of infection control, and, we're safe and everybody's wearing masks, and, please come back. Don't delay your cancer screenings. Don't delay your care. It's really important for you to, your health is even more important during this time. Right. So those have been our messages, but it has been good. I feel like with the telehealth, all of a sudden, anybody who had transportation barriers couldn't get a ride to the office. Now I could see them, right? Or like they had childcare issues, they couldn't leave their kids at home. I can see them while they're at home, with the kids in the background. Or somebody at work, I can't take off an hour and a half, but I can see them now, and I actually can see that they're in their office, So it's been very eye-opening. In some ways, it's like a little mini home visit. I can see what somebody's house is like. They can at least, bring their medicine because they have it with them. They can't give me the excuse they forgot to bring their bottle. And I get, I feel like I get a sense of like their milieu, right? Which is really important. Like you're talking about, understanding where patients coming from. So it's been a really great tool. And, and for honestly, for telehealth, like for a lot of the hepatitis patients, if I already know you, I may not need to really lay hands on you. Like you and I just need to talk about how you're doing with your meds. You can go get your blood work. We can do it over the phone. And so we've been able to, our hospital, we were still doing our Hep B and Hep screenings in the hospital. And the linkage to care part, we offered the telehealth so people didn't have to come in. And so they thought that was a great opportunity. I know around the world, there's been a lot of pivoting. There've been a lot of people get their medications from hospitals. And when the hospitals were shut down, all of a sudden they couldn't get access to their meds. And so I know in the UK, they pivoted and the hospital started delivering medicines to the local community pharmacies so that people could go there. But you hear of like amazing advocacy groups who get on their bikes and deliver medicines to the community people. They are really stepping up because they know the needs of their community to try to make sure people are getting care as they need. But like you're saying, we need to really push the gas pedal because there are gaps. We know that Hep B vaccines have dropped in kids. Not every, a lot of the birth dose vaccine relies on people delivering in healthcare facilities. Right. And so if people if the healthcare facility is overwhelmed or people are afraid to go in, they may do home births instead. Or they may not make it to their pediatric visits, right, for all their pediatric vaccines. So we've seen some models from Imperial College of London just saying that we are looking at potentially, many more new infections from kids born during this time period, which means, down the road, that means more liver cancers that, could have been preventable. So, we're working on some campaigns to appeal to Gavi, the Vaccine Alliance, to really start including the birth dose as one of the vaccines that they cover. And just that patients need to, the community needs to realize that these are life-saving vaccines, and that they need to advocate, right? Moms need to advocate for their kids, and we need to advocate that moms are getting tested. So it's even more important for us to be vocal,
Absolutely,
to cover those
because
gaps.
if people don't know, they don't know to ask for it or to advocate for it. And so our next big advocacy opportunity after today, after our testing day here, is World Hepatitis A in July 28th.
Right. Yeah.
And you have a new theme this year. And what is that? What is that theme?
It's Hep Can't Wait, or Hepatitis Can't Wait. And so the World Hepatitis Alliance will be launching it for World Hepatitis Day, and it's something that we, are hoping, everybody can carry on that message, because it basically can be modified to any group, to any condition. So we have a number of posters that will say, John can't wait for hepatitis C treatment. Right. Or, Manal can't wait for, hepatitis B testing as a pregnant woman, right? Her pregnancy is short-lived, or it'll have a picture of a baby. And so it's very diverse in terms of individuals speaking out, saying they can't wait for, we need treatments, we need testing, we need diagnostics, and they're available. That's the thing. It's not like, with COVID, it's a new disease, everything's still, in flux, but we've had the diagnostics, we have point of care tests that are just not being produced, and that haven't been registered and licensed in different countries, but they exist.
And there are new ones every day. The advances in liquid biopsy are just amazing to me, and all the non-invasive diagnostics that are available and becoming available, I would hope would be able to scale and to increase access to testing and diagnosis for people who aren't within a day's travel of a big machine. And so I think there's a lot of hope, but it can't. You're right. It can't wait. Can't
wait till COVID is over, right? Like, it's probably going to be with us. So we need to just do things even with COVID, right?
Absolutely. So that is the message we'll leave people with. GLI, of course, will participate as a partner in that day, spread that message, and we'll include things with the show notes, so that if people are viewing this show closer to the date, they'll have the most current information on that. And I thank you so much for sharing all this information and insights with me.
It was great being on the show and talking with you, Donna. Thanks for having me.
Thank you. You can find further information at globalliver.org, or follow us on Facebook and Twitter and Instagram at Global Liver Institute. Until next time, thank you. Be well. Stay connected.
Bye-bye.